I want to talk to you about not dying from insulin resistance and all its associated conditions, but I'm going to really reduce it down to some very inexpensive lab you should get, in addition to HOMA-IR, that will make a tremendous difference in your life. I guarantee it. Hang with me. Let's get into this. So what insulin resistance does to your immune system? We're going to do big pieces here, okay? How does this happen? We know that with insulin resistance, all these things are associated with insulin resistance. Obesity, Alzheimer's, dementia, arthritis, various cancers, gout, PCOS, polycystic ovarian syndrome, type 2 diabetes, of course, inflammation, fatty liver, heart disease, high blood pressure, kind of all redundant, erectile dysfunction, all about blood pressure over there. So why? We talked about HOMA-IR before. You're getting that measured of your fasting glucose and insulin. You got your number. If your number is greater than 1.4, you are insulin resistant. Some people are just marginally insulin resistant. They can like duck back and get it out and be healthy again. Others are, it's a runaway train. They can't pull it back. They're 20 and 30 and 50 as a number for HOMA-IR, and you can even be too low. But I want you to see the CGM, continual glucose monitor readings that are kind of associated with this. This is what I call flat and boring. This is pretty normal, maybe a few little peaks here. It's not exactly perfectly flat, but pretty close. Then these waves, if you will, these little mountains start to grow, and we're starting to lose control of our glucose. And it's about insulin, it's about a lot of things, but we're starting to lose as in terms of measurable control over our glucose. Type 2 diabetes is when we are kind of in need of a lot of things, insulin being one of them, and then we've lost control. Glucose is just, anything will set us off. We really need to be vigilant if we care. And our numbers are huge at this point, okay? So that's the context we're coming from. All right, insulin resistance, HOMA-IR, these are all over 1.4, right? So these are all insulin resistant from low to high. These are actual real numbers now with people who have seen me. And I took a swath of numbers, threw them down here, few enough so you could actually read it. Put them all down there, it would be too small and it's pointless. So stage 1, stage 2, stage 3, stage 4, insulin resistance starts. It grows into prediabetes. It gets into diabetes. And after that, if it's still uncontrolled, it does go to cardiorespiratory problems, meaning stroke and heart disease, a cancer. So it's high disability and high death. So here's 3 different ways to measure inflammation. And why are 3 different ways? I like more than one way, but I'm going to show you what I consider a really important aspect of measuring inflammation that you've probably never heard of, absolutely never heard of. And if you have, you probably don't understand why it's important. I'm going to explain that to you so you can go out and get this done on yourself. Okay, 3 different ways to measure inflammation and immune strength. You have white blood cell count, inflammation, C-reactive protein about measuring inflammation, neutrophil to lymphocyte, that's the new part, is going to allow us to measure inflammation and immune strength and to compare them to HOMA-IR, insulin resistance, and why that's important to you. Here's where I get the information. Everybody who comes to see me obviously has labs. The labs go into a spreadsheet, and then from the spreadsheet, I can make my own scatter plots. And that's why I do my presentations on scatter plots now, not on spreadsheets. Like Peter Drucker said, you can't manage what you don't measure. So I'm a big believer in labs. Numbers are something I can get in there and I can change. I can change my own, I can change other people should they follow my recommendations. But numbers are important. You really need to know that, and you really need to not be afraid of it. These are cheap little labs. I'm saying, go get this done. It's tremendous value for yourself. A lot of people are afraid to get labs. Don't be afraid, please. Where this data comes from specifically is from, now we have that CBC. The CBC is this. This is a CBC, which is called Complete Blood Chemistry, which it's a name that's been over 100 years old, back from the 1800s, believe it or not. This is how old that is. And every doctor in the United States, probably in the world, has ever ordered one lab test. It would be definitely they've done this one first. This is like your baby lab test. Everybody's done it. So it's very common and it's very inexpensive, as you'll see. Here we go. It's $20 for the CBC, complete blood count, all right? Now we get that out of the way, and your CRP is 33. You can see CRP, which this has been around for over 100 years. This has been around for maybe 20 years, since the early 2000s. A little more expensive, but now you know where to get it, what it costs, but what we're gonna focus on. So even from the CBC, we're not using all that information. We're only using white blood cell count, and these here, which are all the breakdown of your white blood cells. So your white blood cells are different types. And of those different types, we're going to focus on only 2 types, neutrophils and lymphocytes. So we're going to use WBC, complete blood count, white blood count, neutrophils and lymphocytes. White blood cell count, CBC with diff, as they say. Here's your lymphocytes. This is actually from mine, by the way, from some past lab that I did. Okay, your lymphocytes over here. This is going to be the first wave of inflammation, WBC. Number 2 is CRP. It's going to be on the next page. Here's the rest of the WBC, right? These are all the breakdowns of the white blood cell counts plus lymphocytes. All these are white blood cell counts. But the third way of measuring is neutrophil to lymphocyte ratio, NLR, NLR, NLR. Okay, what do we find? Our insulin resistance, our HOMA-IR number goes up. So now let's look at HOMA-IR relative to age. All the people I've seen, we're looking at about 65 here. Those who are older had lower HOMA-IR. So how you would say that what this shows is those who with lower insulin resistant number, lower IR, live longer, as in the previous slide. So WBC versus HOMA-IR. As your insulin resistance increases, your white blood cell count increases. That's pretty well known. That's nothing clever, and it's boringly well known at this point. What this shows is those with higher insulin resistance have higher inflammation as measured by white blood cell count. WBC, all about WBC. However, those who live a long time, their white blood cell count tends to drop. It doesn't get dangerously low. It's no longer high. It's kind of comfortably relaxed low. They can fight their colds and flus when they need to, but they don't always need to be amped up. This is what this shows. So those with lower white blood cell counts, immune system, live longer. So now number 2, CRP. Let's look at this. CRP versus HOMA-IR. Also, like with white blood cell count, your CRP increases. It's another measure of inflammation, and of course that goes up the more and more insulin resistant we are. Pretty straightforward. So what this shows is those with higher IR, insulin resistance, have higher inflammation, just like we saw on the previous slide. So inflammation equals CRP, and that's why CRP has become this kind of like inflammatory marker that everybody uses. So now we have HOMA-IR versus age. As I mentioned before, as people get older, those who live longer have lower insulin resistance. What about age? As we get older relative to CRP, our C-reactive protein, our inflammatory marker, goes up. So, well, that seems odd, doesn't it? I thought you just said it was good to have white blood cell counts come down low, but our CRP is going up. It's true. It goes up marginally for non-insulin resistant people. Look at, you want to be under 1. This is the CRP range. Under 1 is what's recommended, so that's right below that line. But for all of the people that I've seen in this age range, it's really from a little above 1 as an average of all of them to 1.7. So not much in the course of 65 years or so. Whereas the insulin resistant people started high even when they were young. For the young people that I measured that were insulin resistant, it was already high. And the older people that were insulin resistant, it was even higher. So it tends to go up on both, but it goes up much more with insulin resistance. So this shows CRP increases with age for everyone, but very little for non-insulin resistant people. What does this mean? Why am I showing you this now? Glutathione. All right. So CRP versus glutathione. I showed you this before over here, CRP, C-reactive protein, versus HOMA-IR. And I said, of course, it goes up as your HOMA-IR, as your insulin resistant goes up, your CRP goes up. What about CRP versus glutathione? That's the big antioxidant in the body that we make. Some people make it easily. Some people have a lot of it. Other people can't make it that well, like myself, in fact. We'll get into that in a second. And other people who are insulin resistant have a compromised ability to make glutathione. So they're limited, they're vulnerable. So CRP, as our inflammation goes up, gets higher over here. Those that are insulin resistant, those who were insulin resistant, who had higher amounts of glutathione, their CRP was not very high. So those who are low on glutathione had higher inflammation. But you go, what about non-insulin resistant people? It goes up, their inflammation, remember, it's marginal. So from 1.4 to 1.6, I would call that a straight line, even though I blew it up to make it look bigger. It's a little bit possible edge. So for people who have more glutathione, shows its cause and effect. I believe the inflammation is causing the generation of glutathione to create more. It's a thing that you can create. This brings up an important point about glutathione. There are 2 groups of people that will have low glutathione. Danger, danger, right? One is insulin resistant people, which is what we're going to be talking about today. Decreased amounts of reduced glutathione and decreased ability to generate reduced glutathione. That's the thing that you're after. This group can change by addressing those factors. The other group, those with genomic mutations, have a decreased ability to generate glutathione genomically. So their CAR doesn't work as well. However, you can get in there and fix it. It's a different approach. So there's two reasons: insulin resistance and genomic compromise. Both can be addressed, but differently. Point one, some people are much more vulnerable than others due to these genomic mutations. And if you're interested in looking into that, there's a whole playlist of videos I did on genomic mutations and glutathione and so on. And you can look at that link right above here. We are definitely not all the same. So I get so tired of this one size fits all. Well, Jimmy over there did this. Why didn't I get the same improvement? Or my husband did this. I always hear that one. My husband did this and it didn't work for me, or vice versa. We are different. You're going to have to get used to that. Point two, some people are much more vulnerable than others due to insulin resistance. HOMA-IR number is going to be very helpful here. Here was a study that came out of COVID. I did a number of COVID videos, and it was really interesting. The research that came out primarily outside the United States, but not entirely, was that glutathione was by itself, in its deficiency, made everybody's life worse that had COVID. Giving glutathione to people made them much better. It was amazing. So this is endogenous deficiency of glutathione. Endogenous because you make your own glutathione, right? As the most likely cause, they're not equivocating at all, most likely cause of serious manifestations and death in COVID-19 patients. You can look that one up. That's in 2020, just a few years ago. So what this shows, everybody's exposed to the virus. Some people knock it off and some people don't. Those that are compromised by glutathione that we've already talked about, either insulin resistance and or genomically restrained, and or both, by the way, they basically will allow viral replication to take place. If it gets to be too large and they are already deficient in glutathione, it gets to be pretty advanced. So they call it advanced respiratory distress, or ARDS. Sounds like a pirate, huh? Arr. Or the increased viral load eventually leads to death. And that is something we know that has happened to a lot of people. But other causes, being over the age of 65, that's me. That would be the third cause, right? Low glutathione intake for sure, meaning that your diet and so on and so forth. Genomic predisposition, talked about that. Lower in males, certainly in cigarette smoking, and in chronic disease. Chronic disease meaning chronic inflammation. Look that up. It's phenomenal, and there's a lot to say about it. I'm not going to go that deep. Back to this. This is a breakdown of all those white blood cells, right? So WBC is a general term for all of these. We're really going to be looking at neutrophils and lymphocytes, but what you see is 3 of the 5 different types of white blood cells relative to HOMA-IR increase, just like inflammation, right? That's what this was, HOMA-IR. Inflammation goes up. We got that. But actually 2 decrease. Eosinophils and basophils decrease. So whatever it is that they do, we're not going to have that ability. They're hampered. So one is the release of histamine, which is kind of vasodilation, vasodilatory. That allows us to get all these other white blood cells out to where the infection is. And if you are compromised already, you can't even get the Marines out there to fight the pathogen, okay? So 3 increase and 2 decrease. That's as much as you're going to see on that. And I don't want to go in that direction. So what we're looking at is going to be neutrophils and lymphocytes. And why are we looking at just those 2? One represents two entirely different immune systems. One is what's called the innate immune system. Innate immune system is the immune system of plants and invertebrates, insects, okay? They're present not only in vertebrate organisms, they're also invertebrates, but they're in invertebrates, so plants and insects. Amazing. So the adaptive, or the lymphocytes immune system, is only in vertebrates. Only invertebrates have lymphocytes, have an adaptive immune system. It's phenomenal. That's the first big difference. This is the third way we're looking at, right? Neutrophils and lymphocytes. So WBC, I want to show you how this breaks down. So when we look at those 5 different cell types, what we find is 4 of those cell types are made from one kind of tissue called myeloid. Who cares, right? And the other, lymphocytes, are made from lymphoid. Who knew, right? So when you think about lymph glands or swollen glands, cervical glands, or wherever you're going to feel them, we're talking about lymphocytes in a whole very sophisticated immune system. We're talking about antibodies and plasma cells and everything else. All of that has to do with lymphocytes. All of this quick invertebrate immune system, something we inherited from plants, probably back to the single cell organisms, but I don't know that for sure. It's amazing. So we're measuring the difference between these 2. A comparison of insulin-resistant people to non-insulin-resistant people relative to their NLR, neutrophils to lymphocytes. Neutrophils first respond to inflammation. They're known as the innate immune system I consider like sending out the Marines, take that hill, kill, kill, kill. It's non-thinking, it's non-specific, it's total inflammation. So when you start to get a cold or flu, you start to feel really lousy, that is the innate immune system. Protects your body from infections, killing bacteria, fungal, and foreign debris. Lymphocytes, on the other hand, are very slow to respond. They're not going to help you in the short term. They're going to be what eventually resolves that cold and flu and so on and so forth, but it takes 7 to 10 days for that to get up to be very specific so it can knock out that virus or that bacteria. It's not a general thing. You'll hear things like T cells, natural killer cells, B cells, antibodies. All of that is your adaptive immune system. All of that is your lymphocytes and what develops from that. So this is where the tires start falling off the car with insulin resistance. It happens gradually at first. Let's look into it. Why should we worry about high neutrophil and low lymphocytes? High neutrophils and low lymphocytes. NLR is a marker of disease severity, correlates with death in general, but also with specific diseases. So the normal NLR, these we're getting into numbers now, adult values in non-geriatric, meaning less than 66, I think it is, people in good health, is between 1.8, 3.5. We're going to say, hey, the midpoint is 2.6. Just remember two-ish. We're going to see some other numbers too. These are 4 studies that came out. Look at this. Italy, 2022. That's how important this is. Belgium, 2017. 2024 in China, looking at American Association of Neutrophil Lymphocyte Ratio and all-cause mortality, cardiovascular mortality in U.S. adults, in diabetes and pre-diabetes. We're going to look at that in a second. And then another one, 2021, from the U.S. You'd think it's good thing they're on the board. Okay, so NLR is a cheap, as you now know, an easy to obtain biomarker that mirrors the balance between these two aspects of the immune process. Acute and chronic inflammation, that's neutrophils, acute and chronic inflammation, kind of just like the WBC, just like the CRP, and the adaptive immunity, your ability to manage. So these two things, the other ones don't do that. So conclusion is a positive association of elevated NLR with increased risk of cardiovascular death with diabetes and pre-diabetes in the US. That came out of this one, obviously. As an aside, to show you how important lymphocytes are, there's a company that I use that helps me define nutrient deficiency. It's called SpectraCell. There's no secret about that. But they only use lymphocytes. They don't do anything else. You send in the blood, they filter out the lymphocytes, they grow the lymphocytes for a number of weeks, and they test them against all these things. Only use lymphocytes. They've been doing that for, well, I've been using it for 25 years. I think they've been doing it for about 50 years. So this is just an example. As an aside, here's lymphocytes. So they look for these vitamins, and they give you a nice little way of looking at it. So on this particular one, this is not me, and this time, this person was B5 deficient. I also look at amino acid deficiencies. That's all fine in this person, serine, glutamine, choline. This is where I go for my choline measurement because there is no serum regular blood test you can take for choline deficiency. Other vitamins, D3, A, K2, manganese, and et cetera, et cetera. This is not to sell SpectraCell. It's just that this is all lymphocytes. Carbohydrate metabolism, in other words, insulin resistance or not. Other ways of measuring fructose sensitivity. When have you heard about that? That's a big deal now, uric acid and so on. Antioxidants, glutathione. So I get 2 measurements on glutathione here through lymphocytes and also through serum, which is the other one that you see in the scatter plots. Cysteine, CoQ10, and so on. ALA, alpha lipoic acid, vitamin C. So to that study, we just talked about pre-diabetes and diabetes here. What they did is they took a lot of people, you'll say, and this is in data from the NHANES, United States, and they go for all-cause mortality, death from any cause for pre-diabetics. So they had to define what pre-diabetics were, right? And they had that group, and they measured them, and they found in the course of a 2-year period, what was the NLR number greater than that they died within 2 years. Their NLR, neutrophil lymphocyte ratio, of these people who were only pre-diabetic, that was the only thing, they were pre-diabetic, was 2.06. Greater than that, they died, but it's also, and she's less than that, was no effect. We're going to elaborate on that in a second. Now for death from cardiovascular disease, that level was a little lower. So those who died from cardiovascular disease had an NLR of 2. Higher than that, they died of cardiovascular disease. Or those who died of cardiovascular disease had 2 or higher. Okay, diabetes from all cause. Now the marker is a little lower. The disease severity is a little higher, so the NLR is a little lower. Okay, again, for dying from cardiovascular, it's even lower. So it's a way of using this. It starts to map it out, but I want you to remember, we got 2.06, 2-ish. There's under 2, under 2. Just call it 2-ish, okay? All right, in general, this is the Belgium study. They use median age 38 years old, range from 21 to 66, looking for what is normal. And what this is, these are the numbers here, hard to read, but this is NLR of less than 1, which is dark blue, which is this line right here, and then NLR of over 6, which is this. So they go 1, 2, 3, 4, 5, 6. Obviously, the bigger your NLR is, your neutrophil to lymphocyte ratio, the worse. And they're just looking at 10 years survival, regardless of anything. If you were less than 2, you had a 80% chance that you were still alive in 10 years. At greater than that, and that's how it drops off. So they came up with, basically a scatter plot of their own. And here is also comparing white blood cell count, NLR, CRP, comparing them to each other on a very sophisticated test called sensitivity versus specificity. Who did the best? And what they're looking for here, I'm just being really brief, is area under the curve. And the one that wins is the purple line. The purple line is NLR. That gave the best results in terms of specificity and sensitivity to immune system and inflammation. So here's for all-cause mortality and for cardiovascular health in both cases, certainly way out there for cardiovascular health. Here's the core role of NLR to predict all-cause and cardiovascular mortality. This is used NHANES data again for about 15 years, and that was from China, 2022. So the study was from China, but the data was from the United States. So NLR is all about balance. NLR is all about balance, right? Between neutrophils and lymphocytes. And I'm just giving you a picture to give you that illustration. So it's between inflammation and your ability to control it. It's between neutrophils and lymphocytes. It's between innate immunity and your adaptive immunity. Here's another one from that same study. And what it shows is now it comes up with, it's a huge population of people, of data that they went through, sample size of nearly 3,000. It says that there's a non-linear relationship between NLR and all-cause mortality and cardiovascular mortality. Two different charts. Notice this is 1.75. There's an increased risk of dying from anything. For all these, it's not specific. They are adjusted for age, gender, race, smoking, condition, glucose, BMI, and albumin. What we have over here, it shows also an increased mortality for being too low. That's pretty interesting. So you have a low ratio, which I put a little scales over here. We'll get into that in a second. And over here for cardiovascular mortality, disease specific, that number goes down even lower. So what I'm trying to show you, it's an important number to pay attention to. So what does normal look like relative to scales? We have neutrophils higher than lymphocytes. We have neutrophils and lymphocytes equal. And then we have neutrophils a lot less than lymphocytes. And so I'll start with this one here. This is low neutrophils. You have a little fight. You have a little inflammation. You go, well, that's good. No, we always have oxidation, which is inflammation. We always have oxidation going on. That's how we live. No oxidation, we die. And so when we have a lot of lymphocytes, that's an over, relative to neutrophils, that's an overactive immune system. Too many firemen, not enough fire. What does a healthy ratio look like? Well, specifically this. We talked about it, right? I said 2-ish, 2-ish, 2-ish. So the size of the fire, neutrophils, should always be higher than the number of firemen you have, right? So the neutrophils should always be higher than lymphocytes. Makes sense, right? You need a fire going on to require the firemen. If you don't have any fire, you don't require the firemen. You just need some, you don't need a lot. Fire to fireman ratio, 2-to-1. What about 1-to-1, which I've showed you before? That's not good, because when you think of a fire that gets started, it catches your attention, then you take care of it. You make sure. Think of a campfire. You will have enough around. You don't set the woods on fire and say, oh, gee, gosh, I think we need to do something about it. So it's got to be an appropriate ratio. The appropriate ratio is 2-to-1. And what's also is not good is having too much lymphocytes, right? Lymphocytes and neutrophils. Here's some data. I stretched it out to make it large enough to read. So this is everyone below 2. I simply used 2. Everyone below 2, here's my lowest. And here's everyone above 2. Here's my highest. And so we're going to compare these two cases coming up about what does that mean and what does that look like for them. Okay, so greater than 2 is over here and less than 2 is a biometric is over there. Remember, this is from that $20 CBC test that we're looking at. We're examining this to show you how valuable this is. So coming up, I'll compare these to 0.78 to 4.3. Pretty cool coming up. So what we know is neutrophils go up with HOMA-IR. Lymphocytes go up with HOMA-IR. So the more insulin resistant you are, they go up. But the ratio doesn't really change much. So it shows they go up together, pretty much the same. They're not out of kilter. A little bit, it gets worse and worse and worse, and eventually it does fall apart. But for the most part, at least from my data, it shows that the ratio doesn't change that much. There's a slight increase over here, but not much. So relatively unchanged ratio. Strength of immune system and the size of the fire. NLR, the biomarker, represents the balance of these two aspects. Acute inflammation, neutrophil count, adaptive immunity, lymphocyte count. This is emerging as a diagnostic biomarker. It can predict within a couple years, not like 30 years out, within a couple years, is this thing's getting bad? What do we need to do? I'm going to show you what to do about this, by the way. So it's not all bad news. This comes from this study, US 2021, NLR and mortality in the United States, general population, not disease specific. So from this study, what did we learn? In the course of 15 years, and they did slices of 2-year studies the whole thing through, roughly 32,000 individuals, average age of 30, mean age was 52, and they simply used the white blood cell count with diff, WBC with diff. Neutrophils play a major role in inflammation. Increased in circulating neutrophils is suggestive of acute or chronic inflammatory response. Lymphocytes generate the adaptive immune response. It eliminates, it's the garbage collector. It takes it all out, but it builds up a very sophisticated method for doing that. So it eliminates the pathogen-affected cells, pre-malignant, malignant cells, decreases in circulating lymphocytes occur in association with recent infections. So just after the cold or flu, you'll see it, your ratio will change a little bit. Compared to age, WBCs decrease. So older people have lower levels. I'll show you that. And with age, CRP goes up. You know, that's interesting. What about NLR? NLR really doesn't change that much with age. A little change there. This is for insulin and non-insulin resistant people. Now let's look at the NLR with insulin resistant people, the red line, non-insulin resistant people, the green line. What the heck is going on? As they get older, what we see is their neutrophil to lymphocyte ratio gets more, and the NLR for non-insulin resistant people gets less. What does that look like? So now what I did is I printed it out. These are neutrophils in the blue, and these are lymphocytes in the green. The dotted lines are non-insulin resistant people. So what we're showing is that the neutrophils over the course of age drops more quickly than the lymphocytes for non-insulin resistant people. That's why that number goes down. But for insulin resistant people, the solid lines, the neutrophils and the lymphocytes, the distance is greater. So that's why their ratio is going up. So what does that mean? What they're losing, this is the immune system. Their immune system is it's starting to fall apart. They're obviously stayed around for 80 and they're doing fine at 80, but it's getting worse and worse. Whereas with insulin, non-insulin resistant people, it's the neutrophils that are decreasing. Your chronic and acute inflammation is becoming less and less. You're controlling it. You're healthy. What can we do about it? These are 4 things. They're laying it out there, just like Peter Drucker said, if you can't measure it, you can't manage it. And so this is all about measuring. We find those that are B12 deficient have the highest insulin resistance. Those who are vitamin D deficient have the highest insulin resistance. Those who are omega-3 deficient have the highest insulin resistance. Those who are glutathione deficient have the highest insulin resistance. How is that relevant? Let's look at an actual case. So now we're going to compare these 2 people. Here we go. The comparison, putting this together, 2 examples. Here's the low guy, and he was a 16-year-old male, very depressed. His parents referred him to me and said, can you do something for him? I'm not a therapist. Here's a 40-year-old woman with PTSD, 30 pounds overweight. Can I do anything for her? Again, I'm not a therapist. So I said, well, let's do the labs. So we did the labs, and what did we find out? Well, relative to, 16-year-old boy had low ratio. Why is that low? When you look at neutrophils and lymphocytes, they're both within their range. So if you look at them individually, you miss the picture. And so he's on the low range. Here's the range up here. He's 1.9, barely within the range. 2.4, he's kind of mid-range here, but still kind of, I would say mid-range for lymphocytes. His white blood cell count is 5, and his mid-range there too. His CRP is elevated. Remember, you want under 1, he's basically 3. So for the woman, 40-year-old woman with PTSD, she's high. What's her situation? You look at her neutrophil, she has a big fire. So you have little fire versus big fire, but they both have kind of too few firemen. Their lymphocytes are compromised. So their adaptive immune situation is not really stepping up to be able to handle the fire. There's a danger here. Okay, what about their white blood cell count? Her white blood cell count is at the top of the edge, the top of the limit here. 10 is pretty high. You have to ask a person who comes in with a 10 saying, have you recently got over a cold or flu or what's going on? It's obviously her PTSD. And her CRP is 3. So he goes, well, that's interesting. According to these 2, it said we have a pretty high inflammation. According to this saying, well, something's going on here. Let's look into it. Let's go further. All right, what is their HOMA-IR? The 16-year-old boy is insulin resistant. His insulin is high. His glucose is fine. The woman who's not insulin resistant at all, and her numbers are perfect for insulin and glucose, perhaps a little low on the glucose side. All right, what about the fish oil, omega-3, and the B12, and the vitamin D? Sure enough, for the 16-year-old boy, very low in omega-3. For the woman, remember 8 to 12 is where we're wanting to go, even though conventional medicine says up to 4, conventional medicine. So they clearly have a long way to go. That's something we can do. Their vitamin B12, that's the conventional range. I look at 1,000 being what I want to see in terms of a number. So they're low by my standard by a lot. And now vitamin D, they're low by anybody's standard. 24, 39, 3 things. So if you address these 3 things, do you think the other situation is going to change? Absolutely, it will change. Okay, so what you've learned is why insulin resistance is an important metric of your life, how it affects your immune system, and what's the best method for measuring it. This is why you need to know your HOMA-IR number. For all of these reasons we started this video. Insulin resistance. Stay vigilant, get your labs done. Now you also have your NLR number to get, which is also inexpensive. Till next time. So if this is something that you're interested in, that is a topic that I obviously go deeper in terms of labs, in terms of how to do it, in terms of why you would want to do it, various topics, as you've seen that I've done in the past, then please let me know below in a comment. Till then.